have a table of contents about what I'd like to tell you over 20 minutes or so. I've got to begin with a little bit of a primer. So for those of you who were here a year ago and 2 days ago, a little bit of a repeat. There won't be any quiz afterwards about what I've given you. And then I'm going to dive, as Jonas said, into a prospective randomized clinical trial that we spent the last year getting human studies approval for, and are delighted to tell you we have approval and are just launching it now. So no results yet, but we'll tell you what our trial is. So I have to begin by telling you the major technique that we use at the Brigham and Harvard for investigating fatigue and related exercise intolerance, and that's the invasive cardiopulmonary exercise test. For those of you who haven't seen it, this is it in action in the basement of one of our buildings. Many of you may know about non-invasive cardiopulmonary exercise testing. There's a pneumotachograph here in this gentleman's mouth. It measures minute ventilation and pulmonary gas exchange. What's unique about the invasive version is in his left wrist there's a radial artery catheter, and in his right internal jugular vein a long intravenous yellow catheter with a balloon on the tip called a pulmonary artery catheter. And it's from those things that we're able to take a deep dive into the pathophysiology of what ails individuals with ME and long COVID. And I'll tell you, without the catheters, we're really groping in the dark to a large degree. This is sort of a simplified version of our diagnostic algorithm derived from both the non-invasive variables and the invasive variables from the two catheters. And just to highlight a couple of them, there's the time-honored assessment of aerobic capacity, which is the VO2 peak, or the maximum oxygen uptake at the end of incremental cycling in our case. We like stationary cycles because we don't like patients falling off of treadmills with catheters in them. This is a non-invasive variable. It's very useful in some cases of long COVID with parenchymal lung disease. I won't be emphasizing that at all. All of this is the so-called Fick principle, which dictates that the VO2 is dependent on the cardiac output and the difference between arterial and mixed venous oxygen content at all times. We emphasize at maximum exercise here. So you can explain the rest of the world impaired VO2 peak and associated exercise symptoms that are not due to a pulmonary mechanical limit by really drilling down with this Fick principle equation. We can determine whether the pump limits, the central pump, meaning cardiac output, limits the patient by expressing cardiac output as a percent predicted. And I'll flash by these two. This test was developed to detect left heart disease in its early stages and pulmonary hypertension in its early stages. Patients with ME do not have these things in general. The two buckets they end up in are these two, and I'll just walk you through where we've gotten to that conclusion. One is so-called preload failure, which means that the low VO2 peak and symptoms are related to a low cardiac output, in turn not related to left or right heart disease, but rather related to inability to prime the pump, to move blood physically out of the lower extremities in the abdomen up to the right heart against gravity. I'd emphasize all this testing is in the upright position. If you do this testing supine, you miss the signal. Then the rest of the story that I'll end up telling you about is over here. This is on the arterial side, where we think we have some evidence of vascular dysregulation, where blood flow does not get properly to the exercising muscle mitochondrion. And then additionally, as you heard from our Amsterdam colleagues, there may be an intrinsic mitochondrial problem as well. More on this to come here. So this is how we came to the conclusion that in ME, and just parenthetically in long COVID, neurovascular dysregulation is at play. This may not be the entire story, but we think it's part of the story, certainly in a large percentage of patients with ME. We got into this business back in the day when we were getting referrals for unexplained exertional shortness of breath, it's dyspnea, but related fatigue, lightheadedness, and other exertional symptoms. And we determined that there was a subset of individuals who didn't have any classic heart or lung disease as the reason for this. In retrospect, we learned they all had ME/CFS, or most of them. The things that differentiated these patients without heart or lung disease from a cadre of normal individuals who were referred to our lab, but we couldn't find anything wrong with them, were filling pressures on both sides of the heart. The right side shown here, right atrial pressure, and you can see in the affected individuals with low VO2 peaks, they have lower right atrial pressures, upright at peak exercise, not much of a signal at rest. And in the same vein, on the left side of the heart, with a pulmonary capillary wedge pressure, which is a surrogate for the left atrial pressure, we determined low pressures dictated the abnormal VO2 peak. And when we attempted to regress that VO2 max or peak against filling pressures, there was a relationship. The lower the filling pressure, failure to prime the pump, the lower the VO2 peak, and the root cause was a low cardiac output. So we deemed this preload failure, and in retrospect, we went back and asked more questions, and many of them met the IOM criteria at the time for ME/CFS. So this is how we get into this business. So this is where they land in this bucket. They have mildly impaired VO2 peaks, and they end up with this and none of these other things. All right, we took a little deeper dive now 3 summers ago with Philip Joseph leading the charge. In this particular study, this was an expanded database, invasive database, about 3 times the original number that we had, and we discovered something else. We borrowed readily from our POTS colleagues, who are real smart folks, Dr. Raj in particular. They had done something which we mimicked here during upright tilt table tests, and everybody in the audience probably knows there's a huge overlap between amongst ME/CFS and POTS and related disorders. What they had done with upright tilt table tests was divided the cardiac output response during the upright tilt table tests into tertiles. They determined there was a low flow state, kind of a middling state, and then a high flow state. So we asked the question, does the same thing exist during upright cycling exercise? And the answer is yes. This is preordained. Tertiles of blood flow versus VO2 during incremental upright cycling. And the interesting cohort here to us, the newer one to us anyway, was this red one, which is a high flow state, very similar to that found in a subset of patients during upright tilt table testing. And the mechanism by which their VO2 peak is depressed is not so much blood flow, and this is pulmonary blood flow by the way we measure it. It's impaired oxygen extraction, failure to depress the mixed venous oxygen content. That's what really differentiates them from the other 2 groups. We took a little further look into this. It was becoming increasingly apparent to us, at least initially anecdotally, and then subsequently systematically, that many of these patients referred to us with ME/CFS who had this preload failure additionally had a small fiber neuropathy by skin biopsy. For those of you who don't know about small fibers, they've been known forever to mediate pain, nociceptive function, and I think more recently what's achieved some credibility is that they also play a role in autonomic function. They're known to envelop veins and arteries in other organs, and they play a role in autonomic nervous system function. So we did the skin biopsy as kind of a window into the interior of these patients. All these patients had preload failure, and you can see ME/CFS, and the prevalence of small fiber neuropathy by a single epidermal skin biopsy was about the same as that described in the literature in POTS, about 45%. So pretty high prevalence of this. I'll tell you that with unpublished data, we're now up to about 2/3 of patients with a second deeper biopsy that gets sweat glands. Those are the true autonomic nerve fibers. So high prevalence of small fiber neuropathy. So this is where they land from in terms of vascular pathophysiology. Patients with ME have both preload failure and a subset anyway, additionally, and we've learned more recently, predominantly women have impaired oxygen extraction. This combination, this high flow group of pulmonary blood flow that's very high going around in this circuit, but ineffectual, meaning the blood is not getting to the mitochondrion properly and being taken up properly, is the hallmark, the cardiologists tell us, of left to right shunting. And in this case, we know this is peripheral left to right shunting. It's not central. We know that from the resting right heart catheterization. So ineffectual blood flow going out to the periphery and presumably perfusing organs that don't need it. That could be the skin, the gut, the kidney, and friends. So this is what has led us to determine we think we are dealing with at least a large number of patients with ME who have evidence of neurovascular dysregulation. So this has led us to some what we think are biologically plausible treatments. The first one I wanted to tell you about is mestinon, aka pyridostigmine. So this is FDA approved, and as Gunnar just told you, repurposed drug. I think this is the direction to go in this field, not to wait for 10 years for a new drug. So pyridostigmine is known to act probably in a number of places, but at least in one important place with respect to vascular biology in the sympathetic ganglion, where there is a cholinergic step that then mediates a subsequent adrenergic step. And notice this adrenergic fiber goes out to the blood vessel. So we think we're augmenting cholinergic tone here, but in turn augmenting sympathetic tone to the blood vessels. I'm going to give you a quick case here, just for those of you, for the patients here, near and dear to my heart. So this is one of the early cases we treated with pyridostigmine that really got us interested in this drug. So this was a 32-year-old chief resident at Boston's Children's Hospital, and she came to us with a prior history of being incredibly athletic. She was a competitive bicyclist. She had done quite well in everything in life and her profession until about a year prior when she had influenza that was documented by a nasal swab. And following that, she had the onset of post-viral symptoms, very familiar to everybody in the audience. A lot of orthostatic intolerance and new shortness of breath climbing one flight of stairs. Very, very different from her prior. And by the time we saw her, she had had at least $1 million spent on her on diagnostics that were totally unrevealing, everything one can imagine. We did a maximum invasive cardiopulmonary exercise test on her after a non-invasive one, determined that her VO2 peak was probably about half of what it had used to be when she was a competitive cyclist. Her pulmonary blood flow, the thick cardiac output, was very well preserved. What we now know is this was the high flow group. We didn't know it at the time. She had definite preload failure. These are the right atrial pressures during upright cycling exercise. Normally these go from about 3 up to 10 millimeters of mercury. These were skimming the trees. She had preload failure. Her systemic oxygen extraction by saturations, this should be 28% or so at peak exercise, were 10 points too high. So she had that high flow group, preload failure plus impaired oxygen extraction. And additionally, when we got her skin biopsy, she had a florid small fiber neuropathy. So she is this dysautonomia neurovascular dysregulation that I've described. We treated her with pyridostigmine, and then her program director demanded that before she returned to work, she get another non-invasive cardiopulmonary exercise test. And she had improved to 100%. She emailed me 2 years out from treatment, still on treatment. She was running the Boston Marathon, completed it in about 3.5 hours, and then she lived happily ever after as an attending doctor in Boulder, Colorado. So just an example, but this got our attention and we started treating patients with this. It also led to a prospective randomized placebo-controlled acute study of a single dose of pyridostigmine, here again led by Philip Joseph. What we did was we took 50 women, divided them in half received placebo, half received a single dose of pyridostigmine, 60 milligrams after completing the initial clinically indicated invasive CPET. And we asked what happened to the hemodynamics and pulmonary gas exchange after a single dose or placebo. And the answer was VO2 peak went up, the effect size is small, but remember single dose 45 minutes later. If they didn't get drug, they actually were worse after, and we wonder if this is the beginnings of PEM, rumblings. The mechanism by which VO2 peak went up was cardiac output. It was higher if they got drug, lower if they did not. And the mechanism by which cardiac output went up, we believe, was better filling pressure, shown here with a right atrial pressure improvement. So this has led us to feel a little more confident in the diagnosis of neurovascular dysregulation, and pyridostigmine or mestinon as a potential treatment. A little bit on low-dose naltrexone, which you've heard prior speakers allude to here. We've used it a lot in the clinic with a lot of anecdotal success. It's time for a proper randomized clinical trial, which is where I'm going. Just a little bit on it. It's a mu-opioid receptor antagonist. It's used in 10-fold higher doses than what we use in ME or long COVID for alcohol and opiate use disorders. It's probably a different animal at low dose. It restores natural killer cell function known to be deficient in ME. It antagonizes toll-like receptor number 4, which in turn downregulates inflammation through the NF-kappa B pathway. There are precious few studies of ME patients and related disorders using LDN. There's a relatively large one on fibromyalgia with pretty good success rate and improvement in pain. And then in ME, our Finnish colleagues have presented these data in 200 plus patients who self-reported improvement in exercise intolerance and even brain fog. So I'm going to give you two studies, one of which is completed pretty much and in progress. We call it Baby Lift, and the other is the one that we're about to launch called Lift, the Life Improvement Trial. Baby Lift is a little tongue-in-cheek, but it's a poor person study of low-dose naltrexone versus mestinon versus neither. What we did with an outcome variable was something called the SHAPE test. This is a non-invasive cardiopulmonary exercise test. It's pretty simply administered 3 minutes of a step test with a metabolic cart, and it gets many of the same variables in terms of pulmonary gas exchange that the non-invasive cycling test gets us. And a special call out to Peng Li and Johanna Squires, both here in the audience, who have helped analyze our data retrospectively. So that disclaimer, this is retrospective. Just show you this. It's really well tolerated even with those with orthostatic intolerance. They get to hang onto the bar and self-pace. It's only 3 minutes. It's constant load. We do not have people going to ground, and we do not precipitate PEM with this. These are some of the preliminary results, and I'll walk you through this. We have 57 patients followed longitudinally on average a year or two on combined low-dose naltrexone and pyridostigmine. And our cardinal outcome variable was a time-honored, non-invasive variable, which is heart rate recovery. So if you quit exercise and you see heart rate decay, it's a function of parasympathetic tone and overall fitness. The faster, the better. And what you can see is they improved with a combination of the two drugs. They also improved on mestinon monotherapy. We had 78 patients who just got monotherapy. LDN alone did not have much of a signal, but beware, we only have 11 patients with monotherapy, so I think the jury's out there. And then we had a cadre of patients who didn't get any of these treatments. They were, in general, more healthy. They had better heart rate recovery, and they basically got a couple of POTS drugs or, on occasion, graded exercise training, and not much change there. All right, so now the trial that you've heard about and that we have proposed to start here, it's called the LIFT trial. Another special call out to Johanna Squires, who's spent the last year getting human studies to approve this, and not easy, but we're there. So thank you very much for that. So we propose to do 160 patients, so it's a big single center study. 4 different groups. There's a placebo group, so be useful, as Gunnar said. We have a low-dose naltrexone group combined with placebo. We have a pyridostigmine group alone, and then we have a combination group. So these 4, and we're following them over 3 months. We're going to screen them and make sure they meet the Canadian consensus criteria. Here's our age range. We're going to focus on patients whose diagnosis was made prior to the pandemic. They have to have a smartphone, and we're hoping to get mostly treatment-naive patients. I'm going to exclude the things that you see here. It's a little complicated, but we're going to scale upward in both drugs. Of course, the patient and we don't know what they're getting, but they'll get an escalating dose up to pyridostigmine of 60 milligrams 3 times a day, which is the traditional dose we use in the clinic. And they will scale upward with a low-dose naltrexone up to 4.5 milligrams per day, all over 6 weeks. And then they will continue these things. We have the ability to decrease and increase if there are side effects. But we've had a lot of luck with these scaling dosing regimens in the clinic without patients asking to come off or having to back off. Here are some of our outcomes. At day 0 and at the end of the trial, we'll do a bunch of things, including urine and blood. We're going to get plasma to SomaLogic. We're going to get metabolomics to Elaine Moreau at the University of Montreal. We're going to get PBMCs off to Maureen Hansen and Cornell. And then we're going to have a variety of well-validated questionnaires and a special nod to Professor Sommerfeld about FunCap, which he has just published an enlarged version and a well-validated version of. In the aggregate, these questionnaires get to fatigue, post-exertional malaise, brain fog, and orthostatic intolerance. Every 2 weeks, they'll complete these 3 questionnaires, all remotely and with our computational group. Will flow through REDCap. The Garmin wearable device, we did a lot of back and forth about which one to use. This looks high-end. One of the advantages will be heart rate variability, and then all these other things you see. Patients will wear this continually. If they have a PEM episode in the middle of the trial, we hope to capture it. If they're better, of course, we hope to capture it. So that's it. That's our study. It's placebo-controlled. It's randomized. We hope it leads to some good things. We hope to get this out in mainstream medicine and peer-reviewed medical journals for all to know about and benefit from. Quick thanks again to Johanna, our fabulous computational group at Harvard and Stanford. Wenzong Zhu leads the charge. Peng I mentioned, Joshua Dibble, Maureen at Cornell, Jonas, my cousin, at Uppsala, Elaine Moreau, and Montreal, Ron Davis in the front row, and Linda Tannenbaum, the inventor of Open Medicine Foundation, the founder, and Danielle Meadows, her PhD colleague. We thank them and all of you. Thanks.